Chronic hepatitis. This refers to chronic inflammation of the liver of more than 6 months duration with persistently elevated liver function tests. Chronic hepatitis can progress to liver cirrhosis, portal hypertension with upper gastrointestinal bleeding, hepatic encephalopathy, and hepatocellular carcinoma. Long-term monitoring for disease activity and hepatocellular carcinoma screening with 6 monthly hepatitis B viral DNA quantification, LFTs, abdominal ultrasound, and alpha fetoprotein is mandatory for patients with chronic hepatitis B. Causes include hepatitis B virus, hepatitis C virus, and hepatitis E virus. Genotype 3. Symptoms are arthralgia, recurrent fever, malaise, jaundice, lethargy, mild non-specific symptoms, and sometimes they are usually asymptomatic. Signs. So the signs that are usually elicited include stigmata of chronic liver disease, which are pulmonary edema, clubbing, dupuytren's contracture, parotid enlargement, gynecomastia, and testicular atrophy and spider nevi. Signs of decompensated liver disease are jaundice, ascites, encephalopathy, peripheral edema, in hypoalbuminemia, and purpura or skin bruising in coagulopathy. Investigations are FBC, LFTs, INR, HIV test, baseline alpha fetoprotein, abdominal ultrasound scan, and liver biopsy. For chronic hepatitis B surface antigen as HBsAg and HBc IgG, and hepatitis B E antigen as HBeAg and anti-HBe, and also hepatitis B viral load. For chronic hepatitis C virus antibody testing is required, and hepatitis C virus RNA, and hepatitis C virus genotyping. Treatment. The main treatment objectives are to prevent disease progression and complications, also to prevent hepatic encephalopathy, to improve synthetic liver function through viral suppression, and to prevent transmission. Non-pharmacological treatment. Prevention of transmission to partners, as for example protected sex, not sharing of toothbrushes and sharps, blades, needles, body piercings, tattoos, cultural scarification practices, circumcisions, among others. Also lifestyle or dietary advice, spouse or household screening. And for pharmacological treatment, in chronic active hepatitis B, where HBeAg is positive or HBeAg is negative, the first line treatment, you give pegylated interferon alpha 2A subcutaneous or tenofovir oral or entecavir oral. Second line treatment, give lamivudine oral. For decompensated liver cirrhosis or fulminant liver failure from chronic hepatitis B, first line treatment, you give tenofovir oral or entecavir oral, and second line treatment, you give lamivudine oral. Patients with chronic hepatitis B undergoing chemotherapy or immunosuppressive treatment, first line treatment, tenofovir oral or entecavir oral, second line treatment, lamivudine oral. And for chronic hepatitis C, genotype 2 and 3. First line treatment, you give pegylated interferon alpha 2A subcutaneous or pegylated interferon alpha 2B subcutaneous, and you add ribavirin oral. And for chronic hepatitis C genotype 1 and 4, first line treatment, you give pegylated interferon alpha 2A subcutaneous and pegylated interferon alpha 2B subcutaneous, and also you add ribavirin oral. And referral criteria: refer all cases of chronic hepatitis B infection to a specialist, especially those who have failed first line antiviral therapy or had adverse reactions to antiviral therapy, or have liver related complications like liver cirrhosis, liver failure, liver mass, signs of portal hypertension, ascites, peripheral edema, hypoalbuminemia, and also pregnant individuals and patients with hepatitis B co-infections, for example HIV, hepatitis C, as well as those requiring chemotherapy or other immunosuppressive therapy should also be referred to a specialist. Also, refer all cases of chronic hepatitis C infections to a specialist, especially those who have failed first line antiviral therapy or had adverse reactions to antiviral therapy, or have liver related complications, and also pregnant individuals and patients with hepatitis C co-infections, for example HIV, hepatitis B, as well as those requiring chemotherapy and other immunosuppressive therapy should also be referred to a specialist.